It's indeed a pleasure, I think, to be present in this session with three stalwarts who would be taking us and walking us through the diagnosis of white matter disorders through the MRI and its various new advances. As we know that MRI has really created a very great platform for these diagnoses, and we look forward to hearing from all three of them. They'll be talking about the neurodiagnostic approach that will be taken by Dr. Rekha Cherian, followed by Dr. Nicole Wolf from Amsterdam, who would be talking about hypomyelinations, and Tish Mankad from Gosh, London, who will be talking about demyelinations. And believe me, it's a treat to hear each one of them and the beauty and the depth with which they dissect the approach and limit investigations through a very good analysis of the MRI is something that would be a treat to hear. So with this, I don't think we'll spend too much time on introductions. We'll go straight ahead. Dr. Rekha Cherian to begin. So that I think, is it okay with you, Rekha, that we go straight?
Yeah. I think, and the questions will be taken at the end of all the talks. Is what the organizers.
Like always. Okay. Right. Over to you, Rekha. You could share your screen and begin.
Thank you. Even can you see my screen?
Yeah. Okay. So shall I introduce you, Dr. Rekha Cherian?
Yeah.
Working as a consultant radiologist at the Medal Precision Diagnostic Center, Adyar, Chennai. She has her training at the Christian Medical College, Willowa, subsequently at Flinders Medical College, Australia, and worked at the Lakeshore Hospital and Research Center, Cochin. So we look forward to hearing from you, Rekha. Could you share your screen, please?
Thank you very much. Thank you for the introduction, and thank you, Anne, for the honor of speaking in this esteemed audience. And I'll be speaking on pediatric white matter disorders, a pattern approach. And can you see the screen well? It's fine?
Yes.
Yeah.
Yes.
Okay. Leukodystrophies are genetically determined disorders, and they are characterized by selective or predominant involvement of white matter of the central nervous system. And we're all used to the traditional classification by organelle-based. But when we actually address an MRI practically as radiologists, it's much easier when we have a pattern approach to sort out issues and come to a diagnosis. And we're very grateful to Dr. Vandenap and others who have made this so clear and easy for us to approach. And basically the pattern approach where we collect all the clues and we put them together like a jigsaw puzzle and make a difficult topic like white matter disorders. I know white matter disorders among radiologists is one of the most difficult topics. It makes it actually interesting and actually doable when you use the pattern approach. So it's sort of been a lifesaver to us with regards to white matter disorders. Now, of course, the first clue that we collect is the clinical features, most important, like history, like onset of illness and the type of pattern of illness, and specific features, clinical and examination features. So, and the other important thing is that we should look at as early as possible. When you look at children with white matter diseases, often the earliest features are the most specific. And by the time it goes on to more progressive disease, you lose a lot of the specific features. So very important if we can get earlier MRIs or image very early in the disease. That's one important thing. And the other important thing is if there are siblings, looking at their MRIs can help a lot. So that is very often have been helped by reviewing sibling MRIs, and you're very sure then it is a genetic abnormality you're looking at, and you might get clues. So The imaging protocol is a brain imaging protocol, but you might give contrast in certain cases. And spectroscopy does sometimes very sometimes surprising, sometimes it does help a lot and should be used. And we ideally should image the whole central nervous system, which is the spinal
Dr. Rekha
cord.
Cherian?
Yeah.
Dr. Rekha Cherian?
Yeah.
Dr. Rekha Cherian?
Yes.
I'm very sorry to disturb you.
Yeah.
Kindly, could you please transfer the co-host responsibility to me and Dr. Kshitij Mankad? Because when we will take care of policing, it will be very distracting for you to stop. People are unmuting themselves.
Chicken.
Okay.
So if you transfer the control to me and Dr. Kshitij.
Chicken?
The host is Prasanna Shiroy.
Garam kaise karenge didi?
Host is Prasanna Shirol. Make me and transfer the control to me and to Kish Mankad, to Dr. Mankad. So then you don't have to bother
क्या
about.
chicken मंगाऊं क्या खींचूं?
More on unmute.
सब्जी की जरूरत नहीं है ना?
How do I do that? How do I?
आपने वापस मुझे ना दूंगी. मैं देख लूंगी.
Mr. Prasanna, can you please guide?
Just select Dr. Rekha.
Mr. Prasanna has to do it.
Just select the name. Just go and right click on the name of the person.
Which person?
Dr. Ann. You can go select Dr. Ann's name. Please right click on that.
Yeah.
And you will be able to see options like make co-host or make host, something like that. Please select that.
I think only Mr. Prasanna can do that.
It looks like on his system, it's showing your name as the co-host where you have all the controls now. So.
I don't have the control, Shreya. Nothing is visible here.
Mr. Prasanna, can you log out and log in? I think you'll get that.
Shreya, can you just check now?
Shreya is the host.
Please. I have muted everyone. Please unmute yourself, Dr. Rekha, and continue the talk, please.
Did I stop sharing? Can you see the screen now?
Yes, we can.
You can see, right? Okay, fine. Yeah. Okay. So yeah, so the first step that we often have to do is rule out acquired conditions. So most importantly, are we actually dealing with a white matter disorder? And one of the common things that we need to rule out is HIE and torch infections like CMV. So HIE is usually pretty easy. You know, the preterm injury pattern can look like a confluent white matter disorder, but it usually has that typical gliotic white matter loss, and you see an undulating margin. So even though it has a confluent white matter appearance, you can sort of distinguish it from leukodystrophy due to that appearance. There can be sometimes blood products, but a typical gliotic appearance helps us distinguish. Now, CMV is a bit more tricky in the sense that sometimes, particularly when infection occurs in the third trimester, you get white matter changes, which are periventricular. And while in the earlier on, you might get more cortical malformations, in the third trimester infection, when it occurs, you get white matter changes. So that sometimes does raise issues of whether are we dealing with CMV or congenital CMV or a leukodystrophy. So this is a patient who had typical parieto-occipital predominant white matter sort of patchy changes, which were low on T1. And you can see that also had typical temporal pole, anterior temporal pole cysts, had a bit of calcification in the basal ganglia. So this was very suggestive of CMV infection with these typical findings, and we could give a confident diagnosis. But sometimes it's not as easy. So now I will go through the pattern approach in how we do it. And this is how we would go about.
Sorry to interrupt. Ma'am, can you close the boxes that are there?
Yeah. Sorry, I'm not sure how to close it.
Not a problem. You go ahead, ma'am.
Go ahead. Yeah, it does cover a bit. Okay. So the first step in would be to assess myelination. So that's where we determine whether it's hypomyelination versus a other white matter disorder. And we look at whether it's confluent or multifocal, because this has different diagnostic implications. And look at the predominant location, like in the white matter itself, and whether there is any other structures involved and special features which sometimes clinch the diagnosis. So the first step to assess myelination, of course, my MRI is the only modality, so CT is useless to assess myelination. And white matter, as you can see, progressively in a 4-month-old, the white matter looks white on MRI, and by the time the patient is 1.5 years to 2 years, you get it fully. It's very gray, and that's a completely myelinated brain. Now, this is a 4-year-old child who had hypotonia and motor developmental delay, and you can see the 4-year-old child's MRI shows very diffusely white matter, which is not normal for a 4-year-old child. So this is how a 4-year-old child's brain should look normally, where the white matter looks completely gray and myelinated. So, and this is how a 4-month-old baby's brain would look. So you can see that this white matter looks almost like a 4-month-old baby. So this is what hypomyelination is. It looks like you're looking at a brain of a smaller child. So the white matter changes are just mildly hyperintense. They are diffuse, but only mildly hyperintense. And you can see the T1 also is quite bland. It just looks a little, there's only myelination in the posterior limb of the internal capsule, as you can see, but the rest of the there's not much hypointensity on T1 either. So this child also had a previous MRI, which was exactly the same 2 years ago. And so therefore we would think of this as a hypomyelinating disorder. And you can see again, this child's MRI has only myelination in his dorsal brain stem. So again, it looks like almost like a newborn baby's MRI at the age of 4. So this is a hypomyelinating disorder. And you can see that the Na was mildly elevated, and it was proven to be Salah's disease. Now, the difference why I'm discussing this is that it's important to tell between a leukodystrophy and a hypomyelinating disorder. You can see the difference. This is a normal 4-month-old. This 4-year-old child looks exactly like that. And you can see how bright and hyperintense white matter looks in a leukodystrophy. So there is a definite difference in the signal intensity, which we should be able to make out. So that's the first step, and just a comparison between Canavan's disease and also Salah's disease, the hypomyelination and a white matter disorder. Both show some elevated Na. So just to help with the differentiation of how different the white matter looks in hypomyelination and a leukodystrophy. And the next step is, after you differentiate between these two, you would see whether if the signal changes are confluent or symmetric. So we usually expect leukodystrophies to be quite confluent and symmetric, but acquired diseases are more multifocal. So that's a typical what we expect, but there are caveats, like some acquired diseases are very confluent and long-standing acquired diseases can become confluent. And some leukodystrophies have a multifocal appearance initially and can become confluent later. And so this is just examples to show you how in multiple sclerosis, multifocal patchy, CMV, again, acquired disease, multifocal patchy, while beautifully symmetric confluent in a leukodystrophy. So this helps, but there are caveats. So like, for instance, L2 hydroxyglutaric aciduria starts often as a patchy and then tends to become confluent. This is incontinentia pigmentosa, again, a genetic disorder where you get multifocal patchy areas of altered signal intensity. There's bleeds and altered signal intensity. This is a newborn who had typical skin changes and seizures. And so that can be quite patchy. And these are adult onset leukodystrophies, which can be asymmetric, like ALSP and RS2 related mutations. So this is something that when we report adult MRIs, we have a very high threshold to think. We don't think of leukodystrophies often, but this is something we should remember when we see it can look asymmetric like this even in leukodystrophy. So there are caveats to that. And again, acquired diseases can have a confluent look. So this is, for instance, this is a paraechovirus encephalitis is a neonate, and HIV encephalitis can look very confluent with a lot of atrophy. So there are caveats to the confluent look. And the next step in our pattern approach would be look at the location. So this is the real where we get down to the real, diagnosing it using clues. And the one very important finding is, where is the white matter involved? Is it like this periventricular where you have that sparing of the subcortical Yule fibers, or is it subcortical with sparing of the deep white matter, or is it a diffuse involvement like this? So this, it gives you a very important clue to the diagnosis in some cases. So this is a long list where you get periventricular and deep white matter involvement, typically seen in metachromatic leukodystrophy, Krabbe's disease, and several others which I have listed here. And there are some distinguishing clues between them. So for instance, this 2-year-old child I already showed you, which was metachromatic leukodystrophy with typical deep and periventricular involvement. It can have a butterfly appearance because there's more pronounced involvement of the white matter near the frontal horns and in the periatrial region. So that gives you a butterfly appearance. And we radiologists like to name things after animals and food. So this is another typical appearance, which is tigroid appearance, where you get sparing of the perivenular myelin. So that gives a typical tigroid appearance. So that is metachromatic leukodystrophy with these typical findings. Another disease with periventricular white matter involvement would be Krabbe's disease, which then in this child, there is periventricular white matter involvement. There is also involvement of the dentate nucleus here. And this child was also noted to have thickened optic nerve. So this is a very specific finding for Krabbe's disease. So when you get these combination of findings, so these are all your clues. And when you get these combination of findings, you should think of Krabbe's disease. So just a run through of just some examples of diseases with periventricular white matter involvement, which I've shown you to, and even LBSL, Sjogren-Larsen's disease. So these would help in bringing a diagnosis of these disease by looking at that specific site of involvement. Just the reverse is when the subcortical white matter is involved and there's sparing of the periventricular white matter. So these are some of the diseases like L2-hydroxyglutaric Kearns-Sayre's disease. So these patients have that typical involvement of subcortical white matter. You can see all these areas involved, but the deep white matter is spared. This patient also had predominant putaminal involvement, cerebellar white matter involvement. You can see how how hypointensity is on T1. So that's how a leukodystrophy looks on T1. It looks quite low. And you can see that there was quite a bit of restricted diffusion. So whenever you see restricted diffusion also, that's quite common, and you can see it in some certain leukodystrophies, but definitely mitochondrial diseases with white matter involvement predominantly show this. And this was suggestive of a Kearns-Sayre's disease. So the next set of diseases is when the diffuse involvement of the white matter. This is a much shorter list and it's easier to remember. And I think, when you see a patient with diffuse white matter, it's quite easy to sort them into these by using the clues. Now, Canavan's disease is one of the most well-known ones where there's diffuse white matter involvement. Can start subcortical, but it eventually involves a whole white matter. And usually we see it when it's involving all the white matter. The other typical finding is the globus pallidus involvement and NNA elevation. So when you see a combination of these, I think it's quite convincing that it is Canavan's disease. And you can be quite sure about it when you get a combination of these along with macrocephaly. So this child also had macrocephaly. Another child who had diffuse white matter involvement, 10-month-old child, he had again macrocephaly, no globus pallidus involvement, as you can see, but he had another typical finding, which was anterior temporal post cyst. So this is typical of megalencephaly, leukoencephaly with subcortical cysts. So this is again quite diagnostic. And another white matter disorder, this was a 6-year-old child with a large head and normal intelligence, but hypertonia. And he had, again, you can see there's diffuse white matter involvement, even the gyre looked a little broadened. The ventricles were dilated, and a little bit of pontine hypoplasia. So this was a congenital muscular dystrophy, LAMA2 muscular dystrophy. Now, end stage of leukodystrophies can also have a diffuse white matter involvement. So this child had, you can see it's a very atrophic brain, his white matter is diffusely involved. He also had dentate nucleus involvement and a optic nerve thickening. So this was, because of that, those findings, we could say that it was probably Krabbe's, but with end stage leukodystrophy. And the other process which is diffuse is hypomyelination, which I had discussed earlier. So that is we would have to rule out based on the signal intensity. So again, these are the diffuse white matter disorders, MLC, Canavan's, you use the globus pallidus involvement, NA. Vanishing white matter disease is also diffuse, which I will discuss later, and Mirasan deficient or LAMA2 muscular dystrophy. So this is a shorter list, easier to remember. Frontal predominance, typically we all know Alexander's disease, even MLD can be frontal, and frontal variant of X-linked ALD can look like adrenoleukodystrophy. So just to show you this child with seizures, again, macrocephaly. So you can see that there's diffuse white matter involvement, but frontal predominant. So it's going right out to the subcortical white matter, but it's only involving the frontal white matter. There's also caudate and putamen involvement. So this is quite suggestive of Alexander's disease, and which it was. And this is showing you at the reverse of that, parieto-occipital predominance, typical for X-linked adrenoleukodystrophy, which can show contrast enhancement at the leading edge. So these are ways we look at diagnose this disease because of its location. There are quite a lot of diseases which can be parieto-occipital predominant, like Krabbe's also favors the posterior aspect. X-linked adrenoleukodystrophy, as I showed you, even paroxysmal acyl-CoA oxidase deficiency. And then, as I showed you previously, even congenital CMV, and then neonatal hypoglycemic injury also favors this location. So some acquired diseases do. So it's an important thing to keep in mind. Now, there are certain specific features which can help us clinch the diagnosis, and these are the ones which where you can be quite specific if you are able to identify them. So I'll just quickly run through them. One is, of course, the macrocephaly. If you see that this is a clinical feature. And these are seen in these, typically in these three diseases, Canavan's, Alexander's, and MLC, and a few others as well. But enhancement is seen in these X-linked adrenoleukodystrophy, I showed you, Alexander's disease, and Krabbe's sometimes. White matter rarefication. Now, this is a very helpful finding. One is classically described in vanishing white matter disease, but certain mitochondrial disorders also show very typical rarefaction, and sometimes in LBSL and a few other disorders. So I'll just show you how it looks on. So in vanishing white matter is again one of those diseases with diffuse white matter involvement. So you can see the flare image is normally the flare would look the same as a T2 image because it's basically a T2 image with fluid attenuation. But in this patient, you can see that the flare image has totally gone black. So this is why we call it vanishing white matter, because the white matter has totally, it's become rarefied. And you can see it on the T1 image, it's almost cystic in appearance. So this is how vanishing white matter disease is very typically seen. And this, you can see these small little dots and stripes here is that little bit of spared white matter. So this was diagnosed as, it was an 8-month-old child with a typical history, had regression of milestones after an episode of fever. And the MRI was typical of vanishing white matter disorder, and it was proven to be that. This is another child who was a 1.5-year-old with recurrent episodes of encephalopathy. And the child actually succumbed soon after this MRI, after an episode of encephalopathy. And you can see that, again, there's white matter involvement, but you can see the flare image here doesn't show as much rarefication as on the vanishing white matter. There's still a bit of hyperintensity left, but there are these areas of quite cystic or rarefication seen. And you can see these, the T1, it also looks quite hypointense. There was a bit of enhancement on the contrast image, and there was quite a bit of restricted diffusion. Again, we see this often in mitochondria. And this child had a lot of changes in his brain stem, which is again typical for a mitochondrial disorder, a lot of corticospinal tracts, the central tegmental tracts, a lot of even rarefication in this involvement in the middle cerebellar peduncles, and a big lactate peak. So this was actually a mitochondrial disorder, complex 1 deficiency. So rarefication can be quite helpful in diagnosing these conditions. Then calcification is another very specific, can be very specific in making a diagnosis. This was a 5-month-old baby with developmental delay, microcephaly. there were 2 previous siblings who had died, and their CTs actually had shown intracranial calcification. And so you can see this was a diffuse white matter involvement. So it looks like a genetic leukodystrophy. It doesn't, CMV is usually more patchy, but this was quite a diffuse involvement. There were anti-temporal pole cysts, so more rarification in those temporal poles. And the CT showed this punctate calcification, quite discrete punctate calcification in the basal ganglia. And there was some in the white matter, and there was in the dentate nucleus, which is hidden here. But basically, this was very suggestive of Aicardi-Goutier's disease, which was later proven. And you can just see the difference between the basal ganglia calcification in CMV is more fine, usually. And this was compared to Aicardi-Goutier's disease, where it's more punctate and discrete. And this is another condition where you can see much coarser calcification is leukodystrophy with calcification and cysts, which is another. So there are several disorders which can have calcification, and it can be quite helpful as a feature. Anterior temporal pole cysts, which I had mentioned earlier, seen in certain CMV and in megalencephaly leukoencephalopathy, also with the cystic leukoencephalopathy without megalencephaly. So you can see it in that as well. You can see it in Aicardi-Goutier's disease, which I just showed you, and sometimes in muscular dystrophy. So this is a child with MLC. You can see white matter involvement with the cysts, which is typical. So this is another child who had come for hearing loss evaluation, and we just incidentally found that she had polymicrogyria. She also had these anterior temporal pole cysts. So this is very suggestive of CMV. So CMV and then Aicardi-Goutier's, which I had shown you earlier, can have temporal pole cysts. So just keeping that list of few conditions that can have this helps in narrowing down the diagnosis. Another very important clue, which is the appearance of the thalami. So hypointensity of thalami is very easily seen, and that can lead you to very specific diagnosis. For instance, this was a child with global developmental delay, had a startle reflex and a cherry red spot on retinal exam. And you can see this typical, very pronounced hypointensity in his bilateral thalami, which looked a bit bright on the T1. This is a T2 image. On the T1 weighted image, looked a bit bright. There was a mild white matter changes, more a sort of delayed myelination, little mild white matter changes. And this was gangliosidosis. So typical, this finding is very suggestive of that. This was another child with irritability and spasticity at 4 months. And you can see this hyperdensity on CT in the thalami. And you can see it's quite very well seen on the MRI as low signal on that of the thalamus. And there was some dentate nucleus involvement. There was also, as mentioned before, quite a bit of enlargement of the optic nerve. So this was actually Krabbe's disease. And this finding of hyperdensity on CT and hypointensity of the thalamus can be seen earlier on in the disease and may disappear later on. So that's one thing that has to be remembered. This was another child, 6-year-old with jerky movements, developmental delay, again with thalamic hypointensity, severe cerebellar atrophy, and a little less severe, but also moderate cerebral atrophy. And this was actually neuronal ceroid lipofuscinosis, which again has this thalamic hypointensity. So that it's very helpful to notice this finding because it can really narrow down your diagnosis. Even MLD can have a bit of thalamic hypointensity. So these are the conditions that can have this finding, and just by observing it, you can narrow down your diagnosis. Enlarged perivascular spaces is another important clue, where you can get, you can see this in mucopolysaccharidosis, hypomelanosis of I2 and Loeys syndrome, and velocardiofacial syndrome. So I just show you, this was a child with known Hurler syndrome, came for an MRI, just showed this extensive white matter changes, and there were small enlarged perivascular spaces due to glycosaminoglycans deposition. And you can see that on, again, his FLAIR image showing that white matter with the small perivascular spaces. And typical findings of mucopolysaccharides with J-shaped stellar foramen stenosis, vertebral changes, hepatosplenomegaly. So this is the perivascular spaces doesn't always mean mucopolysaccharidosis. It can also be seen in other conditions. So this was this 8-year-old African child who came with this definite periventricular but white matter hyperintensities with this typical enlarged perivascular spaces. Now this child had, this is again just showing you on T1, the cystic spaces. And this child had 2 sisters who had similar symptoms, and then this MRI of these children showed the same findings. So this was diagnosed as hypomelanosis of I2 based on skin changes and skin biopsy. So this the other thing that we can look at as is their spinal cord involvement. So just going through some of the conditions which typically show this. One is LBSL, HPSL, mitochondrial disorders, and adrenomyeloleukodystrophy, and adult or juvenile form of Alexander disease. So I'll just run through this patient, this 4-month-old child with hypotonia, and you can see that this child had periventricular white matter changes. You can see because it's only 4-month-old, the rest of the brain is not myelinated, so it's not as easy to appreciate, but you can see that it's quite, there's a different signal intensity in this white matter here, and there was some restriction on diffusion. The child had this typical finding of intraparenchymal involvement of the fifth nerve trajectory. So that is the hyperintensity in that region, which is typically seen, and cerebellar white matter involvement, and showed extensive involvement of the spinal cord. You can see the spinal cord is very hyperintense. You can see on the axial image of the spinal cord as well. There was also elevated lactate. So this was leukodystrophy with LBSL with brainstem involvement and lactate elevation, brainstem, spinal cord involvement, and lactate elevation. So the typical findings. And the intraparenchymal trajectory of the trigeminal nerve is also another specific finding in this. So spinal cord involvement, this is one of the common conditions. There are for brainstem and cerebellum, there's also a set of conditions which are typically involved, and I'll just go through one or two. So the maple syrup disease extensively involves the brainstem and cerebellum, and we just saw LBSL as well. So mitochondrial disease also very much involve the brainstem. So we should always be alert to whenever you see a leukodystrophy with extensive brainstem involvement. For a look for a mitochondrial disease. Alexander's disease is another one that in the adult form can involve. So there's to show you a child with typical involvement of the extensive involvement of the brainstem. This is a neonate who presented with encephalopathy. And you can see the brainstem is so swollen and hyperintense, and there's a lot of restricted diffusion. There was also some involvement of the white matter and the thalamus, but the striking finding is the way the brainstem looks, and this is was maple syrup urine disease. This was a child with more chronic maple syrup urine disease, but again, you can see the predominant involvement of the brainstem and the cerebellar white matter. There was also some quite a bit of cerebral white matter involvement. And they can have specific findings on MR spectroscopy due to the branch chain amino acids. So this was maple syrup urine disease. Now, just to go through some of the specific findings again, which help. One is the optic nerve thickening, which we've seen in Krabbe's, but can also be seen in Alexander. Then LBSL shows that intraparenchymal trajectory of the trigeminal nerve. So when you see these findings, you can be quite specific. Again, dysmorphic or notched or zigzag brainstem can be seen in congenital muscular dystrophies. And you can have tortuous vessels in Menkes disease. So there are certain specific features if you look for, you might be able to identify a specific disorder. Spectroscopy, of course, in mitochondrial disorders, LBSL and LTBL also shows lactate peaks, and others like creatine deficiency, you get loss of creatine, you don't have creatine, absent creatine, Canavan's, the NA, and elevated glycine in non-ketotic hyperglycemia. So spectroscopy is the other clue that we add in. So to conclude, I just want to, the pattern approach is that you first rule out an acquired disease, you distinguish between hypomyelination and a leukodystrophy, and then you systematically analyze the MRI and put together all the clues, the MRI findings, clinical and lab. And it's basically becomes very it's a narrowing down based on the findings. And basically at the end of it, we should be able to say at least, are we able to give a sort of lead you to a diagnosis, or it is a non-specific finding. So that is the role of the pattern approach. Thank you.
Ma'am, we can't hear you. Dr. Kalra, we can't hear you. Dr.
Dr. Veena,
Kalra, we
please
can't.
unmute yourself. You're on mute, madam. Dr. Veena, you're on mute. Please unmute yourself.
Anyway, I think, ma'am, shall I thank Dr. Rekha on your behalf? Okay, yeah, she's unmuted.
So it was really nice, Rekha. You took us through the changes with age, telling us how we must sort of look at MRI with respect to age, with respect to congenital infections, and also how to approach the MRI and put all the pieces of jigsaw puzzle together to make a possible approach as to how to investigate further. It was wonderful. Your MRI collections were very, very nice. It was a treat to watch them. Thank you very much. It was really a great talk. So I'd next invite Dr. Nicole Wolf. May I have her CV, please? Shreya? Okay. Dr. Nicole Wolf is from Amsterdam University Medical Center. She's a pediatric neurologist working at Center for Childhood White Matter Disorders. And we know Amsterdam University has done a tremendous work on white matter disorders. She had her training in pediatrics from Heidelberg, Germany. Her research interests include leukodystrophies, especially metachromatic leukodystrophy, and hypomyelinating disorders. And she would be talking to us today on hypomyelinating disorders. Thank you very much and welcome, Dr. Nicole Wolf. Please share your screen.
Thank you so much, Dr. Kalra, for that kind introduction, and thank you for inviting me to give a talk here. I think you should all be able to hear me and to see my slides. If not, please tell me.
Yes, we are able to hear you, and we are able to see your slide too.
Good, good. Just try to advance my disclosures. I don't think conflicts of interest for that talk. And yes, as you mentioned, I'm working in Amsterdam at the Amsterdam Leukodystrophy Center, which was founded by Mario van der Knaap, whom many of you will know. And we are actually an interdisciplinary group doing quite some translational research, but also clinical research. So we work on MRI analysis. We have defined quite a few new leukodystrophies and the causal genes. We are working on natural history studies, histopathology, understanding disease mechanisms, and now also start, and that's also new for me, with the therapeutic trials, which is, of course, very rewarding if you also start to try to really treat those children. So the disorders we focus on, clinical care is for patients with all leukodystrophies, children and adults alike. And our research foci are vanishing white matter, MLC, and Alexander disease. This is Mario van der Knaap, who is covering those disorders. Mark Engelen works on XLD and other peroxisomal leukodystrophies. In my foci, as were already mentioned, are metachromatic leukodystrophy and hypomyelination. And hypomyelination will also be the subject of this talk. You saw already MR images of normal myelination and how normal myelination goes ahead was known already more than 100 years ago. Those are silver stainings of brain slides made by a German anatomist, Paul Flechsig. And you see that even in utero, already some structures, for example, the brainstem, are myelinated. And this process actually progresses through a very stereotyped pattern. Until around the age of 2 years, most of the white matter structures in the brain are myelinated. And myelin, as you know, is produced by oligodendrocytes. Myelin are membrane wrappings, which consist mostly of fat, but also of proteins. And the myelin is first wrapped very loosely around axons and then it matures, which means that those myelin sheaths compact and are squeezed together. All the water is squeezed out of the myelin, and what remains is fat and a lot of protein. This is actually a very concerted progress. So you don't only need oligodendrocytes to myelinate. Obviously, you also need an axon, and this axon should be healthy to actually make the cues for myelination. You need microglia, you need astrocytes providing fatty acids, you need, of course, other factors as thyroid hormones, iron. And this process actually for oligodendrocytes to make those large myelin sheath, which means a more than 6,000 fold increase in its surface, takes only a few hours, which is quite amazing, I always think. So as you've seen already, the MRI is a beautiful method to follow myelination. And you see that around the age of 2 years, myelination is more or less completed. And on T1 weighted images, myelination is even seems completed before that, around the age of 10 months. This is because the T1 weighted images are more sensitive to low amounts of myelin and to the more immature forms of myelin, which is important because in hypomyelination, you will need the T1 weighted images to see about the residual amounts of perhaps a little myelin present. So disorders of myelination are also called hypomyelination or hypomyelinating leukodystrophies, and they're defined as a significant permanent deficit in myelin deposited. And they are diagnosed obviously by MRI, and you already heard about the signal changes you see in hypomyelination compared with other leukodystrophies. So MRIs of children with hypomyelination resemble very much MRIs of neonates. Also in early onset gray matter disorders, you can have impaired myelination. And this is an important entity you have to distinguish from true or primary hypomyelination. In those gray matter disorders, you have early severe atrophy. This is a 2-year-old child with a PIGA deficiency, severe epilepsy, and you see this severe atrophy already at the age of 2 months. The cortex is thin, and because those axons don't work properly, you also don't have normal myelination. And the differential diagnosis is large, and usually the differential diagnosis for early epileptic encephalopathies. And what argues against primary or true hypomyelination, clinical clues, bad visual contact, no milestones reached, early severe epilepsy, and early regression. And the MRI clues, early severe atrophy, thin cortex, sometimes you even see a cortical signal change. You can have signal changes of deep gray matter structures. And this is a different differential diagnosis from hypomyelination. So also in hypomyelination, we can use MRI pattern recognition, which was introduced already by Dr. Cherian in her talk. It was always thought to be difficult or impossible because if you compare those leukodystrophies with the hypomyelinating disorders, I think the differences are more subtle, but they are present. For example, in HABC, you see the atrophy of the caudate and the putamen. In oculodentodigital dysplasia, you have this very pronounced hyperintense signal of the pyramidal tracts. And also, I will show you in a minute, typical changes in the brainstem. In 4H syndrome, you have a relatively better myelination of the ventrolateral thalamus, the posterior limb of the internal capsule, and here the pyramidal tracts and the optic radiation. In, for example, Pelizaeus-Merzbacher-like disease, you sometimes have quite some preserved myelination here in the central white matter, but a clear hypomyelination in the subcortical structures and also in the pyramidal tracts. And Pelizaeus-Merzbacher disease, which you all know, you see a very, very equal signal of the white matter with actually quite thick posterior limbs of the internal capsule, and certainly in the beginning, no atrophy at all. So these little clues actually help you to make a pattern recognition-based diagnosis of hypomyelination. And also the brainstem can be helpful. You see here several different hypomyelinating disorders, and I think you all agree that the brainstems look very different. And this, for example, is oculodental digital dysplasia with the medial meniscus and the raphe involved, which give you this little cross or hot cross bun sign. In 4H syndrome, most of the brainstem and the middle cerebellar peduncus is hypomyelinated, but this medial meniscus is just beta myelinated. In HEMS, it's the other way around, as well as in Pelizaeus-Merzbacher disease. And HSBL, which I show you later on, if there's still time, a little bit more in detail, you see this very peculiar aspect of the brainstem, the superior cerebellar peduncle, and the cerebellar white matter. So what's the typical clinical presentation? Actually, when I started my pediatric and pediatric neurology training a long time ago, we thought that it would be quite severe. So patients who couldn't walk, or at least couldn't walk without quite strong support. And we thought it would always involve nystagmus, spasticity, mixed movement disorder, ataxia, cognitive impairment, although usually much less severe than the motor impairment, and greatly reduced life expectancy. Actually, what we knew from the classic Pelizaeus-Merzbacher disease, which is actually caused by variants in the gene encoding proteolipid protein 1, which is the most abundant structural myelin protein expressed by oligodendrocytes and very important for making those myelin sheaths. The most frequent PLP1 alteration we find in Pelizaeus-Merzbacher disease are actually duplications in about 2/3 of all cases, missense mutations. We also see patients with null mutations, which is in the beginning less severe than the classic Pelizaeus-Merzbacher disease. We can also have triplications and even higher copy numbers, as you see here in a carrier of a triplication. And there are cases with deep intronic mutations causing a relatively mild form of the disease. And the clinical spectrum is also quite wide. You have the very severe cases who have at birth a stridor, severe hypotonia, and don't reach any motor milestones until the patients with spastic paraplegia and onset later in life. And all this depends on the mutation you encounter, and point mutations actually can give you the whole spectrum. And perhaps what's quite interesting, PLP1 is one of the best conserved genes in humans. So our geneticist, Erik Sistermans, who's quite an expert on PLP1, always says all missense variants in PLP1 are pathogenic, and even synonymous variants actually can be pathogenic, which is quite interesting because they are then can lead to abnormal splicing. So if you find something in the PLP1 gene, even an undescribed mutation, be aware that that's probably pathogenic. In Pelizaeus-Merzbacher disease, the amount of the residual myelin correlates with clinical severity. So with more myelin, you are less severely affected. And patients with a pure HSP can have, at least in the beginning, a normal MRI scan. Beyond the brain, there can be involvement of other organs or structures, and these extra CNS symptoms and signs can often point to a diagnosis. Hypodontia, hypotropic hypogonadism, for example, and others. And you see here, for example, a child with this syndactyly, which is typical for oculodentodigital dysplasia. The hypodontia for age leukodystrophy, bone involvement, this chondrodysplasia, which we see in hypomyelination with a spondylometaphyseal chondrodysplasia, a very complicated name actually. And so it's always, but I think you are all pediatricians, so we do that automatically, look at other symptoms and signs. The clinical presentation actually is not as stereotyped as we thought. And even in those children who have all different hypomyelinating disorders, but look actually the same, to have the same amount of hypomyelination, it can be very, very different because this is a child who is wheelchair bound and not able to have significant intentional movements. And this child, actually was a young woman now, has more or less no signs at neurological examination, other than perhaps not being able to stand 10 seconds on one leg. So it's important to keep in mind that the clinical presentation can be very, very mild. And what I just told you for Pelizaeus-Merzbacher disease and the residual amount of myelin correlating with the clinical severity doesn't hold true if you compare different hypomyelinating disorders. The clinical evolution is actually quite, can be quite dramatic. We see a very slowly progressive atrophy. So as adults, many patients have a significant atrophy. And what we also see is in most patients, a slowly progressive neurological situation. And many patients who were able to function quite well as children deteriorate in adolescence or late adolescence and die in early adulthood. And we think that this has to do with a slow axonal deterioration, as myelin is not only necessary for your fast progression of the action potentials, but also for protection and nourishment of the axon. So from the clinical side, we learned quite a lot in the last 15 years. It's not associated only with severe handicap, but also mild presentations are possible. And almost all patients show late and slow deterioration, despite an unchanged white matter signal, and the MRI shows slowly progressive atrophy, and we think that this is due to secondary axonal damage. The causes of hypomyelination. What did we expect actually when I started my training? We expected mutations in other structural myelin genes, for example, myelin basic protein. Think of Pelizaeus-Merzbacher disease and the PRP1 gene involvement. And perhaps also mutations in genes important for oligodendrocyte differentiation and maturation. So large patient cohorts actually were sequenced for candidate genes, but without success. And what whole exome sequencing actually managed to do in the last 10 years is to decrease the percentage of children without a diagnosis in hypomyelination from about half to about 10–15%. And which genes are now involved in hypomyelination? Actually, we did find also structural genes involved, but a huge part were actually genes encoding proteins involved in protein transcription and translation. And this was actually a bit unexpected. And in the end, we have to say many proteins with very variable functions are involved in hypomyelination. And why that is, we haven't understood. When you think back that this huge increase in surface occurs, this must put a big strain on protein synthesis. So this might be the reason why there are so many genes involved in coding for proteins involved in transcription and translation, but that has not been proved yet. So the structural myelin proteins actually did find some present in either the myelin sheath or the paranodal myelin loops, and with different functions actually. And we have those group of proteins involved in protein synthesis and translation, here in MRI synthesis, mRNA synthesis, and in tRNA synthesis. And 4H leukodystrophy is perhaps the most frequent representative of that group. Of the 4H stand for hypomyelination, hypodontia, and hypogonadotropic hypogonadism. Additional frequent symptoms are severe myopia and small stature. There's a broad spectrum of severity depending on mutations, and you can have recessive mutations in either of those three genes, all encoding subunits of RNA polymerase III. And I already showed you the typical MRI abnormalities, and cerebellar atrophy is one other characteristic abnormality. Actually, the clinical course is slowly progressive, as in more or less all hypomyelinating disorders, but in the last years we found also atypical forms. No hypomyelination, for example, especially with polar 3B variants, you only have cerebellar atrophy. Pyramidal syndrome or spastic ataxia with pyramidal tract involvement, especially polar 3A, and actually a disease I've seen in the last 2 years, surprisingly many patients with a disease with a striatal involvement, as you can see here, an atrophy and abnormal signal and the caudate. And those patients have at least one of 2 intronic variants in polar 3A. Another MRI pattern, which was already shortly introduced by the previous speaker, is this hypomyelination and those typical brainstem and spinal cord changes. And this is actually involving the medial lemniscus, the superior cerebellar peduncle, the pyramids, the decussation of the medial lemniscus, and the inferior cerebellar peduncle. This is called HBSL, or hypomyelination with brainstem and spinal cord involvement and leg spasticity. And that's caused by biallelic variants in DARS1, encoding the aspartate tRNA synthetase. And this looks very much like Pelizaeus-Merzbacher disease. Walking without support is usually not possible, but I know a couple of children who have actually learned to walk without support. Acute deterioration is possible. Children develop severe leg spasticity, and they have mild to moderate cognitive impairment. Some develop epilepsy. And there are also milder forms with the onset in 2nd or 3rd decade. Steroids can have perhaps an effect in those patients. Some patients received steroids because they were misdiagnosed as multiple sclerosis. But when you look, for example, at those long tract involvement of the posterior columns, I think you see that this, and actually this pyramids, you see that the multiple sclerosis doesn't look like that. And intriguingly, patients can also have a spinal dysgraphia. And this is also something we saw in the zebrafish model, that there were actually problems with the spinal closure. And this is actually a disease where in India there is one relatively frequent mutation, at least I think that. So you might have seen many more patients than I have with this diagnosis. So what have we learned in the last perhaps 10, 15 years? Hypomyelination are really many different disorders. Genetic causes and disease mechanisms are variable and not well understood, if I'm honest. Severity is very variable. It depends on the factor gene. It also depends very much on the specific mutations. And sometimes we don't understand why some patients are more severely affected as others, especially within families, which is possible. And there is slow deterioration in most patients from adolescence as a common mechanism. And if we think about treatment, we need probably different approaches for different disorders, but also for different disease stages. Thank you very much for your attention. I also would like to thank all the members of the Amsterdam Leukodystrophy Center. And if you have questions, this will be done later on in the question and answer session. So thank you.
Dr. Veena, we still cannot hear you. You are muted again. Please go to the bottom panel and unmute.
Yeah. Can you hear me now?
Yes, ma'am. Thank you.
Okay. Thank you, Dr. Nicole. It was really a wonderful session. You tied up beautifully the role of genes and our understanding and also lack of understanding as to how they are pursuing a different clinical course, which we need to unfold gradually. But it was very, very wonderful to see how you tied up the family, the different MRI patterns along with different genes. It was a wonderful session. Thank you very much. We'll have questions at the end. And now I'd request Dr. Rekha to go on and introduce the third speaker and invite Dr. Shreya, can you share?
Good evening, everyone. I have great pleasure in introducing Dr. Kshitij Mankar, who's the head of pediatric neuroradiology at the Gosh Hospital in London. So I've had the pleasure of hearing him on multiple occasions. And besides all these accolades that are mentioned here, I think we can look forward to a fascinating, exciting talk in the next 30 minutes or so. I can assure you, you will be fascinated. And so, Dr. Mankar, I request you to please share your screen and please do not cut short your talk.
Okay, I'll try not to cut short my talk. Thank you very much. Kind introduction. I did request Anne not to keep that introduction long because I need this time. First of all, friends and countrymen, I hope you're keeping together in these very troubled times. It's very hard for us out of India really to reach out and do anything useful at this point in time. But I would like to express my solidarity and also my heartfelt wishes to all of you, to your families as well. Please keep safe, and hopefully we will all tide over this inflammatory time of our life together, sharing knowledge, sharing information, and just saying hello once in a while. So it's great connecting on this Saturday afternoon from London, out across to the world out there. Hello everyone, and let's talk about demyelination. Thank you, Nicole, and thank you, Rekha. Beautiful expositions about white matter problems. And I think we are still facing the whole issues around terminologies. What is developmental delay? What is delayed myelination? What is hypomyelination? What is dysmyelination? What is abnormal myelination? What is demyelination? I think these terminologies keep kind of recurring in my head as a practicing radiologist as to what should be the right thing to use when we talk about a spectrum of possibilities which on imaging can be fairly non-specific in spite of all the advances that have happened in pattern recognition across various domains of pediatric neuroradiology practice. My acknowledgements, as you see, are quite diverse, spanning mostly clinicians, some of them in the audience as well, I'm sure, as well as pathologists and my fellow radiology friends. And I think together we can make better sense. And that's kind of the legacy we leave behind. Collaboration is key, not just for research, but for clinical practice as well. Nicole very nicely talked about the advances in terms of myelination and its understanding, and it's not just one aspect that we look at, but when we get into the realms of the brain, and this animation here gets us right into the ultra texture, the level where the blood vessels of the brain and the blood-brain barrier that kind of creates a membrane between the brain and the circulation within it, avoiding all that is unnecessary to be put out and everything that is necessary in terms of nutrients passing through that blood-brain barrier. Whatever we talk about today across all the various domains of white matter gone wrong is about inflammation at its basis, if you think about it, and the problem at the textural level. Talking about the blood-brain barrier, there's the endothelium, and then finally the basement membrane, which creates a tight membrane which prevents things from essentially leaking out. Everything that is relevant passes then through the astrocytes into the neurons and nourishes the nervous system. So it's not just the neurons we're talking about, we're also talking about its supportive structures. And when we talk about myelination gone wrong, there's eventually a disruption in this very blood-brain barrier that we talk about, the endothelial dysfunction, the tight junctions getting leaky, and all these various antigens, as I would call them, leaking into the cells, creating this immune-mediated response, whether it is an infectious or a para-infectious phenomenon. Eventually, the astrocytic dysfunction that it leads to not just inflammation of the brain, but finally degeneration of the central nervous system. And this was my running commentary with this video, timed to tell you that there is an interlink between the circulatory system, the nervous system, and we are tied together through these blood-brain barriers and its various levels of expertise. The first commandment of my 5 commandments today are thou shalt respect time. And I'll try to keep to time with this presentation, but I might get carried away, so feel free to stop me. But time is brain is not just relevant to the context of stroke, but also to the context of neuroinflammation and the context of those entities that cause demyelination. And it has been proven many times by many, many authors across the world that timely intervention, timely diagnosis and management, essentially, which is targeted to the problem, alters the natural course of disease and improves outcomes in terms of what it is meaning for the patient as well as their carer community, which is mostly the parents dealing with low EDSS scores and comorbidities that inflicted on these patients. So when I start my talk, I always bring this case back to discussion, this 5-year-old, and my audience today being clinicians, it's an open question to all of you. In the year 2011, in December, 1 year after the first revisions to the McDonald's criteria were released, came across this patient with increasing headaches and fatigue. Not exactly you expect a 5-year-old to complain of many things in that respect. And a scan was done, basic primitive imaging in the year 2011, showing you axial T2 images with lesions distributed in the periventricular white matter, supra and infratentorially distributed across both the realms of the brain, and some of these enhancing on contrast administration. By the time these sequences are performed, the child begins to move. It's restless. It's very difficult to scan children, especially at the age of 5, where you're not even sure if you're doing a general anesthesia or sedation. But we have to live with what we have. How many clinicians in the audience, hand on heart, with the benefit of McDonald's 2010 revisions, would have made a diagnosis of pediatric onset multiple sclerosis at that age enough to warrant disease-modifying agents and therapies to be targeted? In 2011, probably all we had was beta interferon. But either way, the child was not treated as a multiple sclerosis, comes back with multiple episodes of what looked like relapsing, remitting illnesses over the next 5 to 6 years of their life. At the age of 10, 5 years from presentation, this child is commenced on beta interferons, the then standard for multiple sclerosis. But the idea of showing this montage of images to you is to bring back the whole description of what afflicts the brain as an inflammation, finally and very quickly leads to neurodegeneration, axonal loss, axonal transection, and eventually gliosis of the brain, which is not reversible. And therefore, we shall respect time. Radiologists will be specific in their reports, not just non-specific and unspecific. If the criteria for McDonald's are satisfied, we shall henceforth mention that the criteria are satisfied or not satisfied, because our clinical colleagues rely on that report. And that's the message for everyone in this audience. Can multiple sclerosis happen at the age of 5? And that's going to be tricky even in 2021. We had 2 cases yesterday bring to our national meeting talking about the age of onset, who has seen the youngest. And both of those kids were 4 years of age. And this is an old slide now. 2013 was a publication by Harding et al. Talking about the pretty young, very young onset multiple sclerosis. And I'm still waiting for someone to show a cluster, publish the literature out there, and tell us that the very young onset of multiple sclerosis is a known entity, might not be norm, but can happen. And then the whole idea of revising those guidelines again in 2017 was essentially to make the diagnosis early. What we are left with at the end of time is an atrophic, degenerate brain, not just an abundant white matter lesion load. This is a pathology specimen from an older individual showing the white matter plaques, the juxtacortical plaques. Is multiple sclerosis primarily a white matter disease? No, it is not. In fact, the heavy disease load in the cortical gray matter is what finally causes the comorbidities associated with it, the cognitive decline and the atrophy of the brain that transcends all the gray as well as the white matter of the brain. So start thinking about multiple sclerosis, not just as demyelination of the white matter, but actually a problem with the gray matter of the brain. What starts essentially as a very active inflammatory process with oligodendrocytic activation leads on to demyelination and an inactive plaque through the various stages of activity and chronicity, leading finally to smoldering lesions and gliosis, which is irreversible. And that is what we had interpreted on the first study that we looked at. Why would guidelines be revised? Why do you think a bunch of people meet on a regular basis or an irregular basis and decide to write something different? The whole idea is essentially to make diagnosis early, suave, precise, and targeted to the patients. So what are the key messages from the 2017 revisions to the McDonald's criteria relevant to pediatric practice? First, consideration of symptomatic and asymptomatic lesions for dissemination in space and time, which means that we should be looking at cortical lesions as well as spinal lesions, at least at baseline. And the cortical lesions will become more conspicuous when your imaging is targeted to the cortex. Second, dissemination in time and space can be confirmed by new or enlarging T2 lesions. It's not just new lesions in new locations, but enlarging T2 lesions, and that's relevant, not just to the observation, but to the radiology reporting as well. When we start looking at the surface of the brain, we talk about cortical disease, and it has been proven on histology and postmortem that there is indeed a possibility of even imaging, at least in vivo, the plaques that form within the gray matter of the brain, and what seems to be an inflammatory process that seems to start at the leptomeningeal level and eventually makes its way into the deep white matter of the brain. And if we can catch that disease at that point in time, I think it'll make a big difference to outcomes. And whilst you're digesting this new piece of information, I would like to show further research that has happened in this realm in terms of the infiltrative inflammatory activation that happens, the B cell processes that are detected in the cerebral meninges of these patients with MS. Now, this data is all from postmortem in older individuals outside the pediatric age, but how is it different when you talk about the same disease across the two realms? The phenotype of pediatric MS is very similar to that of adult MS anyways on imaging. When the revisions happened recently, we looked at how our accuracy, sensitivity, and specificity changed in terms of looking at our historic cohorts and whether it improved the diagnostic yield. An application of the 2017 criteria did improve performance. So there is a proven methodology here that works. Taking this work further ahead, we started looking at how we could unify the recommendations for imaging children as well as adults in the context of MRI for multiple sclerosis. And this is a paper that is about to be published, and I'm going to show you some excerpts from this paper. If you can, at least the radiologists in the audience, I can see there are radiologists from across the world attending today. This is a bit of a pre-press publication report. The key message is that the imaging at baseline for children should be comprehensive because the demyelination mimics for children are quite extensive. Second, the follow-up should be trimmed because it's hard to scan children. You can't spend 1 hour on scanning the spine, for instance, which is still happening in some centers across the world. So if you look at the recommendations at the baseline of diagnostics, it doesn't matter if you have a 1.5 or 3 Tesla. Important message. Don't chase the Teslas unless you're just buying cars. But in the context of MR scanners, it doesn't matter what you have. The more important thing is every time you scan the children, scan them on the same scanner for standardization purposes. Axial T2, a 3D volume flare sequence, and a 3D T1 post-contrast is all we advocate at baseline. Diffusion has some relevance in children. It's in brackets, it's an optional, but not a recommended sequence. But I think a lot of children, especially with MOG or viral encephalitis, can present with acutely restricted diffusion. That can help. In terms of spinal imaging, we advocate if you're giving contrast anyways, which you should at baseline, do a T1 sagittal with contrast at the slice thickness of 3 millimeters. And at least 2 of the following T2 weighted sequences. Now that is new because all of us probably just do 1 in our centers, but it might increase the relevance of picking up lesions, lesion detection, dissemination in space and time, which can be conferred on the one time point if contrast is administered, i.e. McDonald's criteria can be ticked or scrapped. We do not advocate optic nerve imaging. It's only when needed, and when it's needed, keep it simple. A coronal stir, a coronal T1 fat suppress with contrast administration. With that kind of slice thickness and no gap would be quite relevant. The coverage is important along the optic nerve all the way to the chiasm. And these are some of the images that you would generate through that process. This is a volume T1, for instance, and a volume flare, the mainstay of imaging in terms of MS. Everything else really is quite optional. The axial T2 is a quick sequence. And if important thing is, if you were to administer contrast, which you should in children, at least delay your scan by 5 to 10 minutes before you can do the post-contrast sequences, because the lesion uptake of contrast can be quite variable. The conspicuity is dependent on time. So when your radiologist tells you that we don't pick up any enhancing lesions, I think you should question them. How soon did you do the scan after giving contrast? Similarly, in the spine, this is a montage of what you would expect on a spinal data set. The important message again is for spinal imaging as well, that a delay is relevant. And the lesion type in MS is quite distinct. We shall see a few more examples of that in a moment. The follow-up, as per the Unified International Guidelines, would be an axial T2, a volume flare, and a 3D T1 only. Contrast is not recommended for routine surveillance and should not be used. And the recommendation that we have sneaked into this for relevant for pediatrics is that the frequency of scanning should be 6 monthly intervals for highly active MS. And whilst I can ask you this question, it's a reflection moment for all of you in the audience. What exactly is highly active multiple sclerosis? And you will realize that in children who have at least 2 relapses a year anyways, you would constitute that as a highly active MS. My second commandment is thou shalt be open-minded. And this case, which was sent to me from Nimhans, and it's a beautiful case representing this exact phenomenon, open-mindedness. This patient presented with encephalopathy. Now, what is encephalopathy? I can prove that half of the people in this audience probably are in altered sensorium, particularly on a Zoom platform where you're doing other things. And altered sensorium is one of the tenets of encephalopathy. So encephalopathy is quite a non-specific sign. Add to that seizures, add to that other features. So everyone can be encephalopathic. Anyway, this child was obviously encephalopathic. The lesions are universally hemispheric on one side of the brain. That's the axial T2. You've got a subcortical lesion load creeping all the way into the U fibers. There is some sparing of the cortex. It's hard to show where the cortex is definitely involved, primarily white matter, a bit of an asymmetric ADAM-like presentation. And this kind of dirtiness to the white matter signal is very important in this particular context. Contrast was administered and there was some enhancement which was patchy and nodular in this particular area. And the diffusion weighted sequences essentially were there to show that there was also a long segment optic neuritis. The diffusion weighted sequence is pretty useful when you don't have targeted optic nerve imaging in terms of picking up the optic neuritis in the acute setting. Optic neuritis, patch of lesion, we are talking about demyelination. You're beginning to think what I'm talking about, except that this patient was initially labeled as a diffuse glioma. as a gliomatosis cerebri pattern with breakdown of the blood-brain barrier. Going back to the blood-brain barrier, the enhancement is happening only because the barrier is broken down. Based on that, this particular center, it's a beautiful center, in fact, one of the leading centers in the world, has all the prowess of advanced neuroimaging techniques, did spectroscopy, did perfusion. The spectroscopy showed a choline peak, which was supportive of the gliomatosis cerebri diagnosis, and the perfusion, which was not easy to interpret, showed reduced perfusion in those areas. Hence, this was interpreted as a low-grade tumor in this 14-year-old. The reality is this was biopsied, and the reality is that this turned out to be a condition, and I will tell you the answer in a moment when we have looked at its companion case. In a much younger child, 3-year-old girl who presented after having a cocktail of vaccines because she was flying to Bangladesh. The year was 2007. McDonald's had just released their relapsing remitting criteria for MS, so it was a very important message to the community of pediatricians and neurologists. The imaging was as primitive as the year. All we had was a bit of a signal change around the caudate nucleus there on the left side, bilateral optic neuritis. The child had inability to see, which was clinically correlated, and the optic neuritis was present all the way into the chiasm and probably into the optic tracts as well. That's all we had on the brain imaging, and these were 5mm slices. Okay, so the child was observed, given some steroids, sent home, comes back after a few months, and then comes back again, and then comes back again. So I took 2 time points here. A diagnosis of relapsing remitting MS was made. Is the relapsing remitting ticked? Yes, it is. Is this the phenotype of MS? No. Are these those periventricular lesions, those Dawson fingers that you would put as a textbook chapter example of multiple sclerosis? No. And the child is quite young again. Yet this is relapsing remitting in its nature. What happens to this child? This is the patient journey. This is the endpoint in 2016, gliosis scarring in the brain. For 6 years, they had pulse steroids. Apart from the pulse steroids, 2 years after initial presentation, interferons were administered on a presumed diagnosis of relapsing remitting MS. Did not work. She was switched on everything that was upcoming at that point in time. In 2015, rituximab for the steroids. So for 9 years, a lot of steroids degenerating the brain in the background. 6 years later, this child is switched to MMF and IVIG. And that is based on a presumptive therapy line for a particular discovery that was made in the labs at Oxford in UK in the year 2015. Now, case number 2 and case number 3 are tied with the same diagnosis, that of myelin oligodendrocyte glycoprotein. This child, 9 years into her journey from the age of 3 into the age of 12, now able to speak and express herself, comes to the clinic in December 2016 and says, I have never felt so good ever before in my life. And this is the tale of endurance that radiologists, neurologists, patients, and parents express and go through together. Myelin oligodendrocyte glycoprotein, it's actually a very minor component of the myelin, an oft forgotten component. It's more of a pediatric phenomenon when this is expressed so aggressively. And I think in the audience, we have Dr. Reddy from Hyderabad. He had a great hypothesis that probably it's the immaturity of the brain and the oligodendrocytes which kind of provoke MOG antibodies in much younger children. It's a great hypothesis yet to be tested. But adult literature, in terms of even barn door multiple sclerosis, have demonstrated the expression of MOG in around 20% of those postmortem or histology cases, which means that things can coexist. But myelin oligodendrocyte glycoprotein has a different manifestation to MS. First of all, you suspect it when you have something happening pretty early on. You've got a young child who's presented with slash encephalopathy out there, as you can see, and there is a bit of odd movement disorders. They may have seizures. The child is reported inability to see, again, quite a young child in this particular case. They have multiple episodes of ADEM, and they have longer times to relapse compared to the multiple sclerosis population. So the younger children and who are presenting with ADEM, you're thinking about MOG. What are the neuroimaging manifestations, the many phases? You can have an ADEM-like presentation, or you can have a high lesion load within the posterior fossa, particularly the cerebellar peduncles, as you can see out here. They can present as an encephalitis, which could be acutely restricted on diffusion or bilaterally diffuse at presentation in the context of a post-viral phenomenon. And in this particular case, this child had chickenpox to start with. And then in addition to that, you can have this situation where you have primary involvement of the deep gray structures in time flipping to involve the white matter structures. Deep gray to white matter. All these are the various phases of MOG. And when you encounter a situation like this, you start thinking about leukodystrophies. You start thinking about even whether this is an X-linked adrenoleukodystrophy given its arrangement. The context is important. My third commandment is that you shall adhere to terminologies. Somebody is wanting to draw on the screen. That's great. I can continue. I quite like your graffiti. I love graffiti. I live in London. We are surrounded by graffiti. This very young child, now 20 months, we are going backwards into time. Younger and younger children, we have to pick up things early. Presented with dragging the right leg, 1 day of not using the right arm, and normal loss, there was no loss of consciousness in that situation. And based on the CT, which is still the urgent first line of imaging children, a diagnosis of stroke was made. Stroke, as we all say, is a clinical diagnosis based on the history. A diagnosis of stroke was entertained, and the imaging was said to be supportive. Fine, you can question, was the imaging really supportive? You have a patch of something going on as low density change in the deep white matter, not causing any cytotoxic edema in terms of swelling of the structures around it. The location is not typical for stroke anyways. In a region like this, you should be expecting a proximal infarct with probable changes also in the blood vessels early on. Anyway, the child goes on with a confirmed diagnosis of stroke. Nothing is done. They're only 20 months of age, and an MRI is performed 3 days later. And this MRI performed 3 days later is called monofocal demyelination because, first of all, it is just a lesion. It's not exactly cytotoxic edema. And the vessels are not abnormal. There is a second lesion picked up out there on the MR imaging as a subcortical white matter lesion. And based on the presentation, the child is labeled as a monofocal demyelination. That's a fair point. The important imaging trick here is that you get a broken ring of restricted diffusion, just like you can get a broken ring of contrast enhancement, which is a typical feature for demyelination. So hold your breath, think about this case, and let's look at a companion case. Here's a 7-year-old boy presenting with weakness and fatigue. Couple of lesions, not many, but this large lesion in the brain, a very periventricular lesion, a second lesion picked up on the contralateral side. And when you look hard and close, you can look at this lesion being a very perivenular kind of lesion. It's very MS-like in plaque. It's a very demyelination kind of lesion. They have weakness and fatigue that can go with demyelination quite easily at presentation. But based on this 1.5 image, 1.5 lesions, a diagnosis of clinically isolated syndrome has to be entertained at this point in time because the McDonald's criteria have not been satisfied. And when you have a clinically isolated syndrome, we think about checking the oligoclonal bands. And if they are paired, that means it's questionable. If it's unpaired, it's in the CSF. That means primary CNS demyelination is going on. Now, why is it important to check bands in clinically isolated syndrome? Going back to the 2017 revisions of the McDonald's criteria, that's where it becomes relevant. In patients with typically clinically isolated syndrome, demonstration of these bands allows a diagnosis of MS to be made. Now, luckily in kids, you don't get clinically isolated syndrome, but we all have a cluster of CIS kind of children who have been followed for years together and are still waiting for that diagnosis of MS so they can be started on appropriate DMT. And maybe that struggle will continue for some more years because it is an indeed hard call. But in adult practice, this has made a revolutionary change when patients present with 1 or 2 lesions and the bands are positive. A corollary to that case is this 11-year-old boy where the lesion morphology is very, very typical of multiple sclerosis, except that this was a completely incidental finding in the context of somebody who presented with headaches. And when you have that situation, there's a complete mismatch of radiology, of the white matter lesions, of the suspect demyelination, and the radiologist should be very wary of putting this as inflammatory demyelination. You can call this non-specific, but every non-specific should be kind of followed up with what do you think it is. In the context of the patient who's presented with headaches, we would call this a radiologically isolated syndrome. And the current recommendation is that for radiologically isolated syndromes, we would just monitor them clinically and or radiologically to see what happens. Which brings us to our next commandment, which is perseverance. Thou shalt persevere. This particular case actually brings home that point. 14-year-old girl with a few red flags, as you can see, epilepsy and then consanguinity, very common in certain populations, difficult to image, they're moving around, but the lesions are very paracentral, as you can see out here. Child is presented with vomiting, and you wonder why they're vomiting away, but the sodium has dropped tremendously, and then the sodium is corrected, and then you're wondering what's going on. The initial diagnosis investigation battlefield is all these possibilities that are done, correct? The sodium has corrected to 150. From 111 to 150 is a drastic change in sodium and water balance within the environment of the brain. There are some white cells in the CSF. The bands were negative on this occasion, and the proteins were slightly at 1.8. The ESR was elevated. So is this an infectious phenomenon? Going back to the picture, looks quite atypical for just a primary infection, but we have to, the child was still covered with antibiotics. In the context of this rapid sodium shift, the initial diagnosis given was of an osmotic demyelination syndrome. Don't forget, osmotic demyelination is also a demyelinating syndrome. In fact, any rapid shifts in the salt-water balance within the environment of the brain can cause problems. Generally, it can be pontine or extrapontine, or a combination, as in this particular case, where you have bilateral changes in the temporal lobe white matter as well. And it can result from too rapid a correction of hyponatremia. Now, okay, we know about this in osmotic demyelination. Our child, however, continued to worsen clinically. And in an interval MRI 3 months later shows these bilateral striatal changes. So the initial lesions, which were paracentral in location, have gone away. It has been kind of left and replaced by these bilateral lesions. And the moment we pick up bilateral symmetrical striatal lesions, everyone starts thinking metabolic and mitochondrial. And in fact, when we went back to the history, we said this child had a family history of consanguinity. So let's call this mitochondrial until proven otherwise. And this quest for mitochondrial entities is endless, as all of you know. Anyway, this child was invasively kind of investigated. Everything was negative from a mitochondrial perspective. A repeat CSF shows oligoclonal bands. It was initially negative, probably false negative oligoclonal bands on the initial take. And the oligoclonal bands on the blood were in fact absent. And therefore, this was a primary CNS demyelination. But are these falsely positive on this occasion? Because we have bilaterally symmetrical changes, which is not exactly typical for any form of demyelination that we know of. So the argument continues, people are discussing away, and the child continues to deteriorate in the background. And for the first time, based on their quadriplegic status, a spinal imaging is done. And at this time, there is a large transverse myelitis kind of lesion. And, aquaporin 4 is tested, comes back positive. Now, in this day and age, in 2021, you probably would have done all the antibodies at the same time, but they may not be positive in the first instance. That's the other caveat to be had. This child is finally given a diagnosis of NMOSD and treated with a steroid-sparing agent, and overall does quite well. The big message is that when you have a lesion morphology, which is taking up areas of aquaporin 4 expression in the brain, as in this particular cluster of cases shown very nicely in this publication from 2007, very typical to what our child presented as in this particular cluster, you should be thinking about aquaporin 4. Now, why was the child vomiting? The child was vomiting because we get the area postrema syndrome, and the area postrema shown out here is a very typical location for lesions relevant in the context of aquaporin 4 positivity. And therefore, this slide is very important in the context of childhood demyelination. Case number 1, if you have lesions which are periventricular, lesions in the spinal cord which are discrete, which could be eccentric or dorsal, that's multiple sclerosis. Whatever be the age, you have to look for the McDonald's criteria to be satisfied. If you have lesions that are diffuse, suprainfratentorial, involving the peduncles of the cerebellum. On contrast, they're a bit of irregular punctiform lesions. Spinal cord imaging, you've got longitudinally extensive lesions, a high lesion load in the conus medullaris. And on axial imaging of the cord, you get an H-shaped central cord involvement. Think about MOG. The third subtype is those children presenting with vomiting. Look hard for evidence of an area postrema lesion, but you may get very non-specific lesions or those paracentral lesions in the areas of aquaporin 4 expression. The spinal cord usually is a large, extensive, as you can see, the whole cord is involved on the axial as well, and they can also be quite bubbly lesions, sometimes construed as astrocytomas. This is aquaporin 4. MS, MOG, aquaporin 4, the common 3 relapsing demyelinating conditions. And therefore, an algorithm is recommended when the child presents with the first or subsequent episode of CNS demyelination. You think about imaging the brain and cord. If it looks like adult MS and the criteria are met, a diagnosis of MS is made. If the criteria are not met, it looks like neuromyelitis optica spectrum disorders, which means you should do the brain and spinal cord at baseline, even if it's asymptomatic. You check 2 antibodies. And I think the only change I would encounter here is an arrow here as well. You would check both of them. And if they are positive, you entertain the diagnosis. Now, the chances are, if you have just an ADEM-like presentation, you should still check the MOG. And if it's all negative, consider antibody negative relapsing demyelinating syndromes. And it's important to monitor the child, because if they relapse, you go back to where you started. And this kind of works in the spectrum of many entities. You would come across many other antibodies as well, which may be specific or not specific, but this is a common picture. My final commandment is that of consistency. And this case here, which I will very quickly walk you through, is that of a 14-year-old boy who presented with problems which were progressive in nature. And I'll let you read the rest of the slide. Progressive is a problem. Progressive is a problem. If you look at the imaging of this particular child, they had lesions which look like MS, some periventricular lesions, discrete spinal cord lesions, all the way through, again, some subcortical lesions. So lesion type, if you believe what I've just shown, would be that of multiple sclerosis. The initial investigations, when you investigate more, you find a lot more. And the moment Borrelia was picked up, the initial diagnosis was of some infection, even though there was primary CNS demyelination going on. As you can see, the child was labeled as a borreliosis based on the spinal cord lesions, except that in borreliosis, you get more of a transverse myelitis kind of picture. And in this particular instance, the Western blot comes back as negative. The child continues to deteriorate over time. Now, this was a proper tale of endurance, and I'll tell you why, because this diagnosis has been revised more recently in this particular case. And lots of steroids, but nothing really working over the next 12 months. Everyone's struggling to understand what's going on. And then they had bilaterally symmetrical lesions in the pons over time, along with further clinical worsening. And when you said bilaterally symmetrical lesions, dear radiologists, we start thinking about mitochondrial mimics of demyelination. It is a mimic of demyelination. They had a mitochondrial workup and everything else. In fact, somebody suggested an LBSL kind of pattern evolving with spinal cord involvement. That was excluded as well on genetic testing. So it became quite tricky. And then the child was diagnosed as a relapsing remitting MS based on the lesion morphology, but could not tolerate interferons. So people kept persevering, supporting this child. And then an MDAR test was done around that time, which came back as positive. Now, there is a bit of a caution here. The cautionary tale is that if you have an MDAR antibody coming back as positive or weakly positive, you have to question it. In a lot of entities which are post-viral in nature particularly, you will get this coming back as positive. When does it become relevant? This is not the phenomenology of an MDAR. The final diagnosis in this child at this point in time still remains a primary progressive MS. In 95% of cases in children, you would get a relapsing remitting pattern. But in this particular instance, with the lesions kind of progressing away each time, in 5% of those entities in slightly older individuals, you should still consider a possibility of primary progressive MS. But we mentioned NMDAR, which is very common as an autoimmune encephalitis in children. And its companions are all the other neuronal surface antigens and antibody complexes as could be formed. And these various molecules sitting on the surface of the nerve are very relevant in terms of gatekeeping the calcium and sodium influx and efflux and maintaining the ionic balance across those membranes. And NMDAR particularly is implicated. Now, what are the imaging manifestations of NMDAR? And 50% of cases, the scan can be normal. And in fact, a normal scan can be quite useful to some of the clinicians, because you're looking for somebody who's presented with a psychiatric disorder or a movement disorder. And if you get a normal scan, you know they are limbic in nature and the scan can be negative, and MDAR should be positive, and you shouldn't be treating it for anything else. If you see a manifestation appearing on the scan, it could be a limbic encephalitis in most of the abnormal scans. You can at times see rather non-specific little lesions here and there, but don't forget that you can get bilateral symmetrical basal ganglia involvement, you can get thalamic involvement as well as cerebellar involvement in the context of NMDAR. And as a companion case was this cluster of what looked like Rasmussen's encephalitis also being triggered by NMDAR. So lots of overlap there. And talking about overlaps, this situation becomes quite relevant. And now this is old news, but when we started looking at herpes simplex encephalitis, as in this presentation scan, and the herpes simplex encephalitis causing a hemorrhagic encephalitis and necrosis of the brain over time, this child presented 3 months later with this picture, where we had maturing changes in the early change in early involvement of the brain treated with acyclovir, but we also had a diffuse white matter signal change happening elsewhere, as you can see all across the brain. And the movement disorder was new at this point in time. You would consider what would be implicated as a herpes simplex virus induced NMDA encephalitis. And this picture handed over to me by Dr. Kunanki nicely shows a catatonic state in which this child presented. This child initially had a herpes simplex, comes back a couple of months later with this catatonic state, and then the NMDAR activation that was secondary to HSV. So when we talk about white matter demyelination, you should remember that a viral and a post-viral phenomenon are still the mainstay of considerations in these particular entities. And in the context of NMDAR, the outcomes can be quite variable, as you can see out here. You can get bilateral stroke-like presentations eventually, or a leukodystrophy kind of pattern, or a limbic encephalitis, or even a global kind of insult to the brain. So if you've missed the boat initially and you don't know exactly what was going on, go back and look at the case at its presentation. If I may just use a couple of minutes for my cautionary tales, I always say this now because these are the couple of cases where we missed the opportunity to do anything right. Everything that I have shown you so far is encapsulated in this picture here. This is a 13-year-old girl who looks everything like a limbic encephalitis, could be an MDA, could be anything, could be a brainstem encephalitis at the same point in time, except that everything was thrown at this patient. They continued to progress. And if the child is not responding to the mainstay of initial lines of therapy, your CSF is not exactly helping, the antibodies are negative, and the lesion is extending away in the background, do not rely on advanced neuroimaging techniques to give you the answer, but do a biopsy. And in this case, the final diagnosis was an IDH wild type diffuse infiltrating glioma. Companion case, this was sent to us with a label of MOG from another center. And you can see why. The lesions do look like demyelination, except that they eventually also needed a biopsy because the antibodies and everything was negative, did not respond, and the final diagnosis was an EGG34 diffuse midline glioma. I would like to leave you with this final commandment, and I think this is a time where we need to get together. And I have been speaking to Dr. Nicole Wolf as well, and about our hypomyelination cohorts, for instance. You know, we have to put our cases together because presentation phenotypes and trying to get the patterns right is just one aspect of disease detection. The outcomes can be quite variable depending on the type of morphology the disease presents it. And treatment response assessment is still not standardized across the world. How do we know that someone is responding apart from an EDSS score or some kind of an improvement in lesion load? We're dealing with protocol standardization. We hope to achieve that at every segment of our practice. And of course, we can come together through the endeavors of organizations like the ORDI to create artificial intelligence platforms which can actually be intelligent. I thank you for your attention, and I'd like to leave you with these thoughts and our invitation to our spin class, which is happening. Thank you very much.
Thank you, Dr. Kish, for that excellent talk, as expected. So we have some questions here from the speakers, and with the permission of the organizers, can we go ahead with them? Okay, so
Please.
There's a question for Dr. Nicole that you talked about the variation in presentation of symptoms in the same disorder. So could this be due to variable penetrance, Dr. Nicole?
Well, as this, we see this also in recessive disorders. So I'm not so sure I would use the term penetrance. I think we have to say we just don't know.
Okay. Thank you. Then also, how often do you need to do a brain biopsy if there is an undiagnosed white matter disorder? Is one more question to Dr. Nicole.
Actually, we almost never do a brain biopsy. The experience has shown that usually brain biopsies don't give you the diagnosis. Of course, if you have a child which you suspect from, for example, diffuse gliomatoses, or you think of hemophagocytic lymphohistiocytosis, and you just can't prove the diagnosis with other testing, you might consider that. Certainly forgliomatosis, you need it, but otherwise, no.
You're not recommended. Okay. So, Dr. Kish, there is a question in which someone is asking if GFAP astrocytopathy, what would be the radiological features and radiological clues?
Sure. I think I can add that this is Sridhar Joshi's question, and there is Akbar Muhammad's question about neuromelidiosis. I think both those entities are important to discuss here. They are indeed mimics of demyelination. Now, the few GFAPs that I've seen have essentially shown diffuse white matter signal changes. They don't look like MS. They may look like MOG. I think that's a close mimic, but the context would be important. Now, it's interesting we mentioned GFAP because recent literature is about using GFAP as a biomarker for response in the context of NMOSD. And I think some of you might have read the relevant literature. And I think that becomes relevant only as a follow-up biomarker, particularly when the particular GFAP expression areas of the brain, like the area postrema or the brainstem, are involved. And usually in the context of GFAP, it's a surprise. We don't screen for GFAP on a regular basis, but it is a described entity, it is a known entity, looks very much like MOG, I would say. It can give you spinal cord lesions as well. Neuromelidiosis is an infection per se, so hopefully there will be some markers on the CSF, hopefully there'll be encephalitis. And I really wanted to kind of also bring to discussion the differences between encephalopathy and encephalitis. So if you have an active CSF, in the context of pleocytosis and it looks like an infection, don't lose heart, keep looking for that infectious source until you've given up. Now, it's interesting that I do have a case of neuromelidiosis and it's on my desktop, so I'm actually going to, with your permission, share the screen if that's not a problem, and show you this case. And this is, if you can see my screen here, this is a neuromelidiosis that we looked at. You can see how close it can look to many of these entities. Yesterday, we had a case of a KLH11 mutation, again with large patches of white matter signal abnormality. We are only dealing with something that is showing us a manifestation on imaging. It is very hard to go to the granularity of each of these to say exactly what it is. The context is so important. Having those discussions on a regular basis is so important. And going back to the CSF, I think, is more important in many of these cases.
So another thing, you talked about that case, the child with headache, the radiologically isolated. Do you have any series on what happened to these children on follow-up?
So haven't really put a series together, but I think that's again a very good collaborative question, Rekha. From memory, and I've got Karuna here from Philadelphia. I can see an Atin Kumar from AIMS as well. I guess Nihal is on the call. Feel free, the radiologists in the audience. So many times we would encounter lesions that look like demyelination, and then we try to say it in a meeting with the clinicians. They laugh at us because they don't think it's going to be demyelination. Everyone's right. And what we have seen in the follow-up of these lesions is that the lesions don't change over time, yet they keep getting getting scans on a regular basis, that's fine. I think radiological monitoring has a role for reassurance, but by and large, things don't change. So Karuna, please feel free to share your views as well on this, because I think it's a radiologist's delight when we start picking up these lesions, but it's our despair as well because we have to monitor them on a regular basis. Nothing changes. By and large, they remain quite static in time.
So I cannot. Dr. Kalra, any questions?
I think, yeah, there's one question I want to ask Dr. Mankad. We get some children, more pre-adolescents, who do come with something that looks like a clinically isolated syndrome, and for following them up for many years, they are pretty well. They're pretty well preserved. And it's a very big dilemma because having to start interferons is not easy for the family or for the doctor. When do you call it a point that these children should be given just a methylprednisolone or an IVIG and left, or be followed up more rigorously?
Interesting
Considering
question.
the fact that MS is not such a common entity in the Indian context.
A couple of things, I'll break that down. And it's interesting that you ask a radiologist this question, because I will try to attempt it, but I'm sure people who want to put discussions in the chat, Lokesh is on the audience as well. You've got some great guys out there, Vivek is in the audience, but this is how I would take it. The longest I've seen a CIS taking to connect into an MS has been 7-8 years. So it is a long time. And if the lesions are not increasing, radiologists are very obliging. We will be happy to rescan. We can do a very kind of abbreviated follow-up 3D flare only to look at the lesions per se. If the lesions are remaining the same and you've said the child is actually not changing, why would you actually then treat them as MS? I think it's completely a clinical call at that point in time. And of course, you're right, interferons is not going to be an easy game for many of these children. So we've had CIS, remaining CIS or as a label for 6, 7, 8 years before it's finally converted to MS and DMTs. The good thing now is, I think, in the context of DMTs, you have access to a lot more agents like ocrelizumab, things that can be tolerated much better. So if you do feel like treating these children because things are changing, their fatigue levels are increasing or the EDSS is dropping, I think there are some better options and better interferon available. And you guys know better than I do in that respect.
What about, see, point is, some of the times when you get a CIS, the radiologist reports back that all the lesions don't appear to be of the same age. So that does create a little bit, it's happened very recently in one of my patients. The episode is first, but the radiological lesions appear to be very distinct in time.
I don't think on the sequences that we do that we can make that assessment. So it is an erroneous judgment call to make based on T2 weighted sequences, whether something is old or new. I can buy that if some of these lesions are restricted on diffusion and some are not restricted on diffusion. Even the cystic, what does a cystic lesion mean in the context of demyelination? And Nicole can correct me because Nicole and her team are doing a lot more pathology related work. A cystic lesion in MS, I don't believe that T1 holes exist. I think it's just a lesion that has been there for a long time. But I don't think radiologists can and should age lesions based on standard T2 or T1 weighted sequences.
So there's another
I'm
question
very happy to see. I'm very happy to see that scan for you, Dr. Veena Kalra.
I really want to see, because there's been a very distinct reporting saying that these are very distinctive in age, whereas clinically the child has had just one episode.
Yeah. More importantly, if the lesions are increasing in number or the individual lesions are increasing in size, I think that will be more relevant rather than trying to establish their age based on cystic appearances.
There's another question for Dr. Nicole. Dr. Vivek Jain wanted to know that the MTHF mutations can present with significant hypomyelination on MRI in infancy. So would you recommend homocysteine levels be done in patients with hypomyelination?
Thank you for that question. I haven't shown you the difference between delayed myelination and hypomyelination. So you should always also think of delayed hypomyelination in young infants. With delayed hypomyelination, with delayed myelination, I certainly would advocate metabolic testing. I haven't seen a child with hypomyelination and vitamin B12 or folate deficiency. I know that also the folate transporter defect has been described with hypomyelination. I've seen in the meanwhile quite some MRIs of patients with that, and it's more a delayed myelination than a true hypomyelination. So I think I still have to come across a child with a hypomyelination and a folate deficiency.
Okay. So, question to all, whosoever can answer. I mean, what are the views on white matter changes seen in infants with COVID infection? I think burning topic of the day.
I would like to take this
Dr.
opportunity to, I'm sorry I'm stealing the microphone here, but this is a relevant question and Vinu has asked this question. And I would like to know from you all, because you're still in the thick of the pandemic, how is the pediatric COVID seen in terms of the brain and spine? Because I know there is a lot of other things going on in the adult population, like mucormycosis and all that. What are you all seeing in children? And I can share with you what we saw in London over time.
What we have seen is visual changes, a child having blurring of vision. We have seen a GBS-like syndrome. We have seen isolated neuropathies, and we have seen encephalopathic picture in some of these children.
Like Dr. Kalra and I were just discussing this morning, since so many of the children do have positive antibodies, so how do we correlate with I mean, a lot of para-infectious syndromes are coming along. So whether they are independent of COVID or post-COVID or MISC, whatever. So it's still not clear to us.
I'm just trying to share with you all the kind of spectrum of possibilities that we saw with our COVID population. The important thing was we had stroke-like presentations. Then we had the ADEM-like presentations, which were pretty much looking like MOG, and all these patients were tested for MOG as well, but were negative. We had ANEC-like presentations in the very young children, especially in the neonates. We had neuritis in the context of GBS kind of neuritis, as well as cranial neuropathy. So it is not a surprise that you had optic neuritis kind of changes, inability to see. And we also had cranial nerve inflammation and enhancement without actually manifesting as cranial nerve signs. Our initial kind of cohort was only these changes where we had transient splenial reversible changes, a bit of deep white matter change in the cerebral hemispheres bilaterally, as you can see out here. And rarely did we encounter the secondary HLH kind of triggering with microangiopathy, etc., in the brain. We also had myelitis in the context of acute deterioration with transverse myelitis of the cord. And all the antibody tests and the primary infection screens were negative, apart from the fact that they were COVID positive at various stages. The other thing which is not shown on this picture we saw was myositis, inflammation of muscles in random locations. It could be a peripheral muscle, or it could be even in the skull base and things like that. So these were the kind of things that we saw with the COVID population. And if you're beginning to see like this in India at this point in time, it'll be very useful to put these together in terms of the appropriate timelines matched to the primary infection and or a remote kind of change from the primary infection. Given that the virus has a direct and indirect effect in the brain, as in it causes an infectious and para-infectious phenomenon at the same time, from what we know of it, I think we are going to see a combination and a mixture of features.
So there's another question for Dr. Wolf from Dr. Nihal. He would like to know how you would categorize and term genetic white matter disorders on imaging. And do we still need to use terms such as dysmyelination, or do we move towards terminology as per Dr. Vandenap's 2017 paper on the classification of leukodystrophies?
Well, I think the term dysmyelination is very confusing, and at least we don't do it. We don't use it. I think the pathological classification is, of course, very much leaning on findings at pathology. We don't have for all disorders, certainly not for the ultra-rare new disorders. And this is certainly something we all should work on. But we should try to use clear-cut terms, and dysmyelination is not a clear-cut term. So that's the reason why we don't like it.
So, but it sometimes becomes very difficult on a clinical basis to put into all those, to fit in the cases in that classification sometimes.
Yeah, but you need the MRI, of course, to fit them into the classification.
Yeah. So even with the clinical and even the MRI pictures, sometimes it becomes very difficult to fit into the exact group. So
yeah, I agree. It can be difficult.
I think even hypomyelination essentially is a radiological descriptive term. If you think about it, looking at the mismatch of T1 and T2 weighted sequences. And Nicole will agree that hypomyelination itself is not a very pure term when we start looking at diffuse hypomyelination and patchy hypomyelination. So they are quite descriptive morphological terms. They have come to stay the way they are. Dysmyelination probably relates to just an abnormal myelin of any nature, but the term is of no use even if it's used on a radiology report. But I think it just tells us that this is an abnormal myelination of some degree. The thing is, we focus a lot on myelination. If you think about white matter disorders, is it all myelination that we're talking about? How much of the brain is actually myelinated? Maybe 15, 20% at its best. The rest of it is unmyelinated white matter. So that is also potentially involved. And I think there's too much of a focus on myelin when we talk about leukodystrophies, when actually every component of the system, and as quite nicely shown by Nicole on our opening slide, is involved and affected. And I think it goes back then to the blood-brain barrier and what's happening.
So anyway, going through all the list of questions, we can see that out here we've seen the whole spectrum of para-infectious, disorders following COVID. That's what I can see. So, Dr. Kalra, any more questions?
Yeah, I was asking Dr. Nicole one question and Dr. Mankad another one. Dr. Nicole, do you know what are the important epigenetic factors for the PLP gene-related disorders having very different manifestations?
Well, I think the PLP1 variants are actually quite stereotyped in their presentation. So in the PLP patients, also in families, I don't see so much variation. So I'm not so sure whether epigenetics is important for PLP1. For age, for example, that's really different. There you can have a very, very wide spectrum even within one family. And whether it's epigenetics or other polymorphisms or infections, viral infections, for example, we don't know.
Thank you very much. Thanks.
So, yeah.
Dr. Mankad, now to label these COVID, the question that Rekha raised a little while ago, just a COVID antibody positive at a stage when they've come with the neurological symptoms, is that enough to put them in this category? Or do we need exclusion of the entire other gamut of investigations? What is the minimum diagnostic criteria that should be applied in this category?
I don't think that's been defined yet. And the bigger problem is the synergism that COVID has shown with other infections. And I thought that India would actually witness, like Brazil did, a sudden surge in pretty bad and aggressive forms of tuberculosis, for instance. What we also saw, and this is unspoken truth because we couldn't really publish it, the causation and the association is so hard to tease out from each other, was an increase in demyelinations presenting quite aggressively. And, you know, they were proper MS kind of demyelination or MOG kind of whatever, but there was a synergism that this whole thing called cytokine storm or etc. was making the brain vulnerable to. So in the kind of situation that you are working in is in India, with where infection is so fraught, I don't think it's easy to do nothing but pinpoint it on COVID and let it be, because it is a phenomenon that is existing. Maybe when the pandemic is over, I think this is better teased out in retrospect and in for future really. But around when a pandemic is going on, you have to do all the tests anyways, whichever your resources allow you. But I don't know whether you have shared a similar experience with tuberculosis flaring up pretty badly and in weird locations in the body in the context of those who are COVID positive, for instance. And I think synergism is a bigger problem than trying to get the hygienic diagnostic criteria at this point in time.
So we did see a lot more CNS tuberculosis than we usually do in our hospital. But we couldn't exactly say whether it was the government hospitals were not seeing any, taking any cases other than COVID patients. What the reason was, we couldn't kind of pinpoint. And like you said, it may be a retrospective kind of analysis.
I would definitely encourage you all to publish your observations, which will be extremely relevant. I know you're all busy treating patients right now, but I'm sure there are people in the audience who might be more attuned to wanting to put things together. And I think the message is important because every paper should promote thinking. It should not be gospel. It should just be a piece of work that should encourage people to think on other lines. And I think the synergism is not exactly a published piece of info either. But as I can see, Shefali has put it in the chat group as well, that, there is bad tuberculosis going around. More than you expected.
So, Dr. Kalra, if there are no questions, shall we? There are no further questions.
Thank you very much to all the speakers. It was really wonderful to have such a wonderful plethora of information from really the horse's mouth, and to particularly the genetics part in hypomyelination and the newer thoughts in the demyelinating disorders. I think they were an eye-opener. Thank you very much. Thanks for all the speakers. Thank you, Anne, for organizing. Thank you, ORDI. Thank you, Dr. Rekha Mittal, who was with me. Thanks to all the people in the audience who participated so actively. We thoroughly enjoyed the session. Dr. Rekha, whatever you'd like to add and wind up.
Yeah, I'd like to thank all the three speakers. It was excellent, and it was very in the blink of an eye, like you say, the evening was over, and it's been a really wonderful evening listening to all the speakers. And I thank the ORDI and Dr. Anne and her team for inviting me to chair this interesting session. Thank you very much to the audience for joining this evening. Thank you very much, everyone.
Thank you.
Dr. Anne, would you like to sign off?
Yes, please. And thank you, Dr. Nicole Wolf. Thank you so much. And thank you to all our speakers for staying in. I'm really sorry about the initial problem, but this is our next session, our next speakers. Please stay tuned for more education next Saturday. Thank you very much. Thank you, madam.